Hello and welcome to another U of Care podcast. My name is Oliver Grundmann, and it's my great pleasure to welcome Dr. Catherine Striley for this podcast episode. Dr. Striley, would you mind introducing yourself?
I would love to introduce myself. Hi, I'm Kathy Striley, and I'm an associate professor in the Department of Epidemiology. I'm also Deputy Director of Health Street, our community engagement initiative here through the Clinical and Translational Science Institute. I'm also the Director of the Masters of Science in Epidemiology and the Certificate in Psychiatric Epidemiology, which is an online program that people take who are interested in getting some additional expertise in psychiatric epidemiology wherever they are in their career.
Wow, that sounds like a very diverse set of positions that you occupy there. Sounds like certainly keeps you quite busy, all of these positions.
That's true, it does. I'm also on the CARE Executive Board right now, and I'm just thrilled to be a part of the center, which I think is doing such good work and encouraging junior faculty as well as our pre-docs. And I have 5 pre-doctoral students in epidemiology, all of them working in the drug abuse area. 2 of them are T32 members through Sarah Jo Nixon and Linda Kotler's T32 program training in drug abuse research.
Oh, wow. Yeah. So my first question is more directed towards your personal journey and what got you interested in substance use disorders and addiction in general. I think we all kind of have our own journey of what got us to the point to actually conduct research for personal or professional reasons interested in this subject matter.
Well, like many people, like most people in America, I do have substance abuse history in family members that led to quite a bit of problems for a sibling and one of her children. And so definitely there is a personal angle to my interest. But I had kind of a non-traditional road to get here. I started out with my bachelor's degree as a litigation paralegal for a big law firm, and then decided that I really wanted to do more work related to helping people with problems get the care that they needed, which is kind of the story of my life. And so I went back to school to get my master's in social work. And after that, started working and worked in that field for about 10 years. I was not doing predominantly substance abuse treatment. I was doing mental health treatment and neurological kinds of disorders and family work. But I did have a kind of a crisis with one of the people I was working with where a not good thing happened in a hospital. And I just really wanted to learn more about what we could do to help, because I didn't feel like our society was really doing a very good job on the treatment side of things. And so I did go back and get my PhD. My PhD is from the Brown School at Washington University. So it's multidisciplinary. It's social work, but we had to have at least 3 different disciplines as a part of that in our program. And I was an NIMH pre-doc in biostats and epidemiology. And, part of that program met Linda Kotler, who was teaching epidemiology in the medical school, and ended up becoming a postdoc with her, and stayed on in faculty and then came down here when she came down here. So the work that we were doing just sort of hit my sweet spot in terms of trying to figure out what was going on in a person's life, the way that person understood it through their own self-report, both qualitative and quantitative research and mixed methods research, and then trying to figure out, where are sort of the actionable steps, where are the places where there are teachable moments for that person, and not just that person, but really the professionals that we put in place to support somebody and help them get the care they need, there's a lot of points where things go wrong. And of course, the first one is that a person with a need never gets hooked up with a person who could help them. And we miss the whole phase of recognizing that they need services. And that's certainly something that I've pursued a lot in terms of understanding nosology. And how do we decide that something is clinically significant and something is a pattern of symptoms and behavior that means that that person could benefit from treatment, versus it just being sort of a normal phase that they would come out of. And, we're surrounded by things that can addict us. At all points in our lives, we sort of have these pulls on our behavior. And I consider it to both be a very compelling area of research to really understand what's going on with people, and again, where we can get some inroads to help them get the help they need, but also to really understand how we're defining those problems and what's the whether or not something is truly causing a use disorder, what we used to call addiction, what we used to call dependence, but really doing that. So I've done research in caffeine. I'm currently doing research in kratom. I've done research in vaping and energy drinks, and just looking at some of those things that we don't necessarily consider drugs from a classical standpoint, but that can be very addictive for people.
Mm-hmm. Yeah. My understanding from the perspective of the intersection of the social surrounding environment, the social influence and impacts and variables, as well as how we look at it from a healthcare provider perspective as a pharmacist coming from the College of Pharmacy, and also from just the society perspective of the punishment approach that is still heavily seen and viewed, at least in the US, we primarily pursue it as punishing a person who has particularly a substance use disorder.
Right. I think.
Yeah. That incarceration is kind of the number one way to not treat. It's not a treatment, right? We just basically put somebody, incarcerate them, and we consider that the way to go to punish somebody, instead of actually providing them, as you said, with adequate resources to address the underlying multifactorial variables that got them to that point where they are experiencing a substance use disorder.
Yeah, so go ahead.
So from that perspective, you have been involved with Health Street for many, many years.
Yeah.
And that has now become, I mean, it's not only in the state of Florida, from my understanding, it's expanding beyond that. And there were many studies that now have been conducted. What is your perception of where you as a researcher see that we can really make an impact as researchers, as scientists, on society to really potentially change how society views substance use disorders and people, not only the person affected by it, but also the social environment affected by it?
Yeah, that's a really huge question, and I want to answer that in a couple of different ways. The first is that Health Street, when Dr. Kotler started Health Street in 1989, it was predominantly geared towards HIV prevention and working with people who were out of treatment. And that's continued throughout Health Street's history, the emphasis on people, not patients. And not institutionalized people, but people in their communities. And the second aspect of that is like, who is working with people, and that's other people. And I know that sounds really trite, but the idea here is that we're working with people wherever they are and in the situation in which they find themselves. A lot of studies have been done in patients. And of course, those people have already found themselves to care, and they don't need us to find them. They're already there, whether they're patients or they're in treatment. But going to people who are out of treatment, whether or not they want treatment, because that's an open question, requires us to approach them again as people. So we use community health workers, and those community health workers are, the plan is always that they are peers, that they are very relatable, that they are culturally sensitive, that they have some street savvy, that they are able to just approach complete strangers and start to build a relationship of openness and trust. And we've been really, really lucky to have some absolutely terrific community health workers. And I want to highlight a study that we did at Washington University, but in the greater St. Louis area, where we, that I will get to answer your question, I promise, but where what we did is we took women that were in drug court. So these are women who have been arrested for some of them for basically prostitution, but all had some kind of a drug-related charge. And we actually went into the courtroom on the judge's invitation and had someone there who offered these women to enroll in our study. And while they had a probation officer and a judge who was really on their side and trying to help them get a life that would be free from substance abuse, we would come alongside them with our community health worker in a van and help get them wherever they needed to go. So the judge would say, get your license, get your children back, get in treatment, don't have any drugs in your urine when we do urine checks. And then our community health workers would function as extended friends, as extended family members, as sisters. A lot of our community health workers and the people they were working with chose that language of sisters to help them. So Health Street has this huge potential of having these people who are more relatable and more able, who can come alongside people and really see where they are right there without judgment, and then put very practical, concrete things in place so that the person can improve their whole life. And that's going to be probably getting to treatments, maybe some self-help, but it's also going to be very practical things like food and a safe place to live and potentially a peer group. I love Health Street as a model because the promise that's inherent in it is what I think a good society should be. It's a community. It's a community that comes alongside and wraps around the person with very natural kinds of supports to help them figure out these are the things I need to do to get my life where it should be. And with the help of this person, with their support, I can do that. So
I think you brought up an interesting point that people who are not currently patients, who are not seeking actually, or who are not in treatment, no matter if that is for a substance use disorder or who are taking something that we would not consider an illicit drug. You mentioned kratom, for example, your involvement with kratom, which is currently not scheduled on the federal level. We know that there is a potential. We discussed that before we started the interview, that I also have an interest in kratom, that there is a potential for dependence with kratom use, but that a lot of people are taking it for pain relief because they are afraid to take opioids because of their dependence potential. Right. So I think there's a lot of education needed, a lot of education on both sides, the side of the regulators, the side of healthcare providers, and also the side of people who are taking it to to provide necessary guidelines and advice on how to safely take some of these substances that are kind of in a gray area of regulation currently, where I would hope that we can educate and be there as healthcare providers and through Health Street potentially to guide such people who are engaging with such substances. What is your take on something like that?
Yeah, so you open a door and I just see all these paths in front of me that I want to take. So I have to keep following where I'm going with that. So one thing is kratom, and I want to come back to the kratom study. But before we can get to specifically kratom, the thing that you mentioned that's intriguing to me, and I keep looking at in terms of research, is, what is it people are looking for out there? We have this very professionally, scholarly outlook that tells us, people are looking for sedation, or people are looking for stimulation, or, these kinds of things. And really, when people are deciding what drugs are safe to take, we've done some studies, like we did a club drug study where people would tell us that they were professional drug users. And what they meant by that was they were very self-educated about exactly what they were taking, about exactly what kind of results they could expect, and what the potential side effects and problems were of those drugs. And so they were looking at things like, which is the exact thing to buy, and what's the dosage, and what's the best route of administration to get exactly the effect that I want. So I think that we often underestimate people's desire to be pharmacists, to really understand what they're putting in their body to get what they want. And I think we're seeing this with kratom. We are looking, we're probably going to be writing a paper. We're starting to work on a paper using Reddit as a source for kratom. There's 9 different subreddits that we're following, looking at both positive and negative expressions related to kratom. And so this potential to educate people is real. I mean, people are hungry for information. And they want to know, is this a safe drug? Is it not a safe drug? And I think we have to get there with our work. And if you remind me, I may get back to that thread. But going back to this idea of people really pursuing the education, unfortunately with kratom, there is just so much we do not know, as you know. And I was very lucky through Dr. Chris McCurdy and a center here to be able to get some moonshot money for a pilot to interview 80 people with kratom, and to develop a kratom use disorder section for our substance abuse module. So when I was talking about my preparation, I didn't mention that I also got a master's in psychiatric epidemiology for the only program in the world that had a master's in psych epi at the time, which was at Washington University. And I ended up becoming associate director of that program. And in that program, one of the things that I got very familiar with and ended up being on the teaching faculty of was the diagnostic interview schedule, which was first used in the epidemiological catchment area study in 1980, early 80s. And then the World Health Organization did the CD based on the DIS, and Linda Kotler was in charge of the substance abuse module to that. And for this kratom grant, one of the things I did is add a kratom unit to the substance abuse module, and that is programmed. It's all administered online, on a computer, and that module now will assess whether or not we can come up with a use disorder pattern for kratom. We also did a scoping review of all the literature on kratom. And as you know, there's not much out there that has to do with people and their response. There's some animal work and some pharmacological work, but not a lot that is people's reports about taking kratom. But we did find 36 case reports that fit our inclusion criteria. And these were mostly poisoning kinds of incidents. and liver damage, cardiac problems, respiratory problems, and some psychosis and mental health issues. Those were all reported, as well as some seizures and a neonatal abstinence syndrome as well. So there are some consequences of use. And again, there are different kinds of kratoms, there's different preparation, there's different ways of consuming it, routes of administration, and dosages. So there's a lot to know about the frequency someone's consuming it. And this is what this instrument does, is it helps a person to self-report the information we need to know. What did they take? How often did they take it? When did they take it? Were they using other drugs with it? Were they using it as a replacement for opioids? Did they have some physical problems because of it? Did they have some psychological problems? Were they not fulfilling their role functioning because of it? Did they try to stop? Could they stop? Did they feel that they were developing some tolerance? So all those things, we really need that information so that we can feed it back out to people and let them know, if the government doesn't move to classify it and it is still freely available, then this is the safe parameters, or at least we can help people understand the consequences if they continue to use it in a way that is risky.
Yeah, I think that is definitely a very important validated measure to assess kratom as a potential kratom use disorder, so to say. If there is such a thing, then we definitely should be able to evaluate it. I completely agree. So in the remaining time that we have, and I know you and I, we could talk about that for longer because we're both really interested in this, and also obviously, Health Street. I encourage everybody, no matter if you are associated with UF Care or not, if you are part of the general population interested in Health Street, this is an ongoing. I would consider it a nationwide initiative by now that really has made such a large impact on communities that I encourage everybody to definitely look into that. So, Dr. Striley, aside from your tremendous involvement and the impact you have made, what else keeps you busy, or what else do you do to compensate a little bit for your work, for your research work? What are you doing outside of work to compensate a little bit, to relax?
Well, I love to hike. So whenever I get a chance, I like to go to Paynes Prairie or to Millhopper or to San Velasco, as well as my daughter lives in the Atlanta area close to Stone Mountain, and there's some wonderful trails in there that I like to get to go to. And I don't have, as much time to do that as I would enjoy. And I look forward to birding when I retire. I enjoy the app iNaturalist, and posting things on iNaturalist that I find in my neighborhood, in other places. And I like puzzles like many people do. I have a 58-year-old niece who lives with me. I'm her guardian, as well as my husband. So I don't have a lot of free time. How's that?
Yeah.
I also like to do advocacy work, and I'm on a number of groups. One that I'm really interested in promoting, I guess, is a solo seniors group in the area. And there are so many issues that affect older citizens in our in Florida as a whole, but in our nation really, that aren't getting the attention that they deserve. So I'll just throw in a pitch for that.
Thank you very much, and I think that is definitely very important when it comes to advocacy in particular. I think we have to realize that there are many issues, especially when it comes to, for example, mental health, that need to be addressed when it comes to marginalized populations. And I think we often underestimate how, especially in this area of COVID-19, how elderly patients, that's seniors, but also those who are kind of removed currently from their direct connections with family, are really feeling very much isolated. So I think it's very important to mention that. Okay. Thank you so much, Dr. Striley, for taking the time today to talk and be interviewed on this podcast. Thank you, everybody, for listening to this podcast. And as always, we look forward to a future podcast. And take care, everybody.
Thank you, Oliver. Thank you, everyone.